Hey, exchangers of gas. Welcome to the Gas Exchange Podcast, where we talk about anything respiratory critical care. Remember, the information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. My name's Keith Lamb, and I'm the host. I'd like to welcome my co host, Thomas Piraino,
Hello.
and our special guest today, Dr. Zafar Khazam.
Hi, how are you?
Dr. Qasim is a world-renowned emergency medicine and critical care physician, researcher, and educator, and we are so fortunate to have him here today with us. He's also really interested in trauma resuscitation and all things to do with trauma. Welcome, Dr. Qasim. Can you just tell us just a little bit about yourself?
Yeah, sure. Well, thanks so much for having me. It's a great honor to be on the podcast with you guys. I'm Zafar Khazam. I'm in Philadelphia at the University of Pennsylvania, emergency medicine and critical care physician. I'm going to split my time between both locations and have a strong interest, as you mentioned, in trauma resuscitation, but really also kind of trying to bring elements of critical care practice down to the emergency department. So that we can ensure optimal care for our really sick patients. So thanks for having me on the podcast.
Of course, welcome. So you bring up a really excellent topic. We could talk to you about tons of different critical care topics. I sort of want to focus probably on emergency airway stuff that the respiratory therapists would be most interested in. But you bring up an excellent topic in terms of bringing critical care to the emergency department. Tell us a little bit about maybe 10 years, I guess, there's sort of been a paradigm shift in terms of like bringing the ICU to the ER because of lag times and getting people out of the emergency department. And tell us a little bit about how that transition has occurred.
Yeah, sure. Yeah. I'm a strong believer in, one of my mentors in particular told me that, critical care shouldn't be defined by location. The patient's sick. They don't care whether they're in the emergency department or the ICU or even in an ambulance. If they need critical care, we should be providing that. And we shouldn't be really siloing care just based on geographic location within the healthcare facility. So I think more and more over the last decade or so, we've seen papers that have highlighted the importance of early critical care intervention. Specific to you, things like making sure that we're achieving appropriate tidal volumes for ventilation. We see that um, there is a delay often in adjusting things to optimal evidence-based settings in the transition from the emergency department to the ICU, often for several hours, if not a whole day. And so ensuring that you're achieving that goal early on can be really beneficial for the patient and certainly has been shown to improve morbidity and mortality. But the general principle really is even more important these days. Certainly we've always had a problem with boarding in the emergency department, but it's become much more acute in the post-COVID era where, sometimes critical care patients may spend 12 hours in the emergency department before there's a critical care bed for them to go to. And so it's really important for the emergency physician or the emergency medicine team to be able to understand how to apply critical care principles to their critically unwell emergency department patients. And that's not even taking into account the patients who across the country, in North America in general, end up at critical access hospitals where it may be hours before a transport option is available to get them to a tertiary care facility. And so, really we need to move away from the idea that critical care is isolated to the intensivist and the ICU. Critical care is everybody's realm if they're dealing or managing a critically unwell patient.
Yeah, I think you bring up a really good point is that, if we wait until they're in the ICU, there's a lot of opportunity for issues to start happening immediately, especially when someone is intubated and ventilated. And like you mentioned, there's often delays for getting a bed from emerge, transferring a patient to ICU. So some patients could be in the emerge for much longer than you hope they would be.
Yeah.
The ideal situation is the minute they get tubed, they're gone, right? But
Yeah.
this just isn't the reality. I mean, during COVID, it certainly wasn't the reality. For many hospitals, they had to wait until someone came to pick them up to bring them somewhere else because there's just no room. So yeah, that's an important task to have, trying to introduce these critical care concepts into the emergency department.
Yeah, for sure. I mean, we've seen this not only with optimal ventilation strategies, but also with things like sedation. People are under sedated in the emergency department, may spend several hours at that less than ideal RAS score than they should, even when they're moved to the ICU. I want to say there's a little bit of an inertia when patients are moved. Certainly, their ICU colleagues are busy with other patients. A new patient shows up, they presume things are optimal, and it may take a little while for things to be able to be understood that actually we need to change things. But your audience, I'm sure, knows, and yourselves know, things like ventilator induced lung injury will start early and,
Mhm.
can potentially become irreversible or chronic problems for these patients if we're not addressing those issues up front.
Yeah, I think we've all experienced I mean, I've been working over 20 years in the ICU, Keith even longer, but we've all experienced those nightmares that come in through emerge that is just impossible for them to manage down there simply because of acuity, and it's not necessarily it's not a clinician issue, it's an acuity issue, and then they come and then we're spending hours of trying to sort them out. So the fact that you're trying to implement some of the practices that we stick to in ICU in emerge, I'm sure is welcomed by many clinicians. When they receive a patient, there's not much setting adjustments we need to do because they're on lung protective ventilation, right? Like these something little like that when they come in is like, those sound like lung protective settings, and you put them on the ventilator and you're happy with the plateau and the driving pressure. You're like, okay, great. They did a good job down there. But you're right. If they come and they're on like 100% and a people 5 and, 10 mils per kilo of tidal volume, you're like, I don't know what was going on down there. But you just assume it's acuity, but it's a lot nicer to know that there's some knowledge translation some gaps with knowledge translation that are being addressed anyways.
Yeah. And I think we have to acknowledge, the fact that, the emergency departments are busy and they're getting
Hmm.
busier. And,
Yeah.
one of the big factors in optimal critical care management is not what we as physicians do. It's really kind of how our extended team helps us. In particular, I think the nurses, the nursing ratio in the emergency department, even for critically ill patient, is not what's achieved on the ICU. And that has a big factor in it. And that really led us to kind of look at our institution about how we could achieve optimal lung protective settings, for example, for our patients. And we actually decided that we'd do something simple. So in our intubation like cart where our video laryngoscope is attached, we put a tape measure so that RT can come and
Mhm.
measure the height of the patient and then provide that information to the clinician who could then, in their order set, plug in that data to provide the optimal 6 or mils per kg or whatever they want to set for the patient to try and achieve those things. So utilizing the broader team is really important and really emphasizes that, everybody's involved in the critical care management of these patients. It's not just the clinician that's there. It's really the wider team that provides that optimal care. And that's how we can really change things by including them in the early management, just to kind of offload some of the tasks in order to optimize care.
Yeah, and I think we shouldn't, or we should highlight the importance of the respiratory therapist in some of these decisions and discussions, because when I mentioned we've all received patients that were sort of really complicated or like a mess, as for lack of a better term, from whether it's from outside a hospital directly into ICU or through emerge or from emerge, we have to understand that there's the role of the respiratory therapist to advocate for the patient for lung protective strategies. And oftentimes, depending on the autonomy that exists, I guess, in certain hospitals, the autonomy may not exist, and so they're just following orders. So if the physician says put them on these settings, there's really no questioning. They put them on those settings. But I think there should be a there should be some encouragement from respiratory therapists to start the conversation at least about lung protective ventilation. If they're in an institution where you don't have physician leads that are trying to implement this stuff, if they're just writing orders and you're following them, there really needs to be open discussion saying, you know what, I think we should do this. So there is a responsibility also on the respiratory therapist. And I don't want to make it sound like it's just the physician's fault if there's not lung protective ventilation being used in the emergency department. We really need to take some ownership on that as respiratory therapists and have those discussions, being obviously kind to each other and not starting arguments at the bedside because you don't agree with the ventilation strategy. But yeah,
Yeah,
I think there needs to be open dialogue, really.
I agree totally. And I've worked at places where RT has been a kind of the quiet shadow in the background and not really provided input, and other places where I've had good back and forth discussion about what things are going on. I think that the biggest thing that I've seen is that a lot of times respiratory therapy will be called when everything's kind of spiraling. The patient needs to be intubated. Suddenly, they go call RT and then they come to the bedside and they don't know what's going on.
Who?
Is
What?
this
Where?
patient
Yeah.
Why?
a
When?
head bleed that needs a different type of
Yeah.
kind of targets, or are they in ARDS or something else? So I encourage my residents to, when they're talking to me about how they want to intubate the patient, I go, well, what vent settings are you going to put them on? And then I say, okay, here's the respiratory therapist. You guys have to work together to
Yeah.
get this patient safely intubated and ventilated afterwards. And I think that's really important to emphasize and include, because if you don't, then, it's kind of on you as well that, you didn't have that conversation with your team and they're just trying to do what they think is right. But if they don't have the information,
Mhm.
then, how are they going to be able to provide optimal care? And then an hour passes and you realize that, something's wrong here, and really kind of everybody needs to take ownership of that. But I totally agree. People need to understand, all the members of the team need to understand what's happening with the patient, why we're moving to managing them in XYZ way, and what we expect in terms of, their ventilator management and sedation management and things like that.
Yeah, definitely a team sport, and communication is pivotal in education, especially in a place, tertiary center where a lot of educating is going on, and a lot of learning and a lot of teaching. So this transition and movement of critical care to other facets, emergency department, um, has even moved even pre-hospital, right?
Yeah.
Where where we're bringing ECPR, ECMO to the grocery store or wherever, right? I have
Clean
a
up on aisle 5.
Yeah.
I have a slide and a couple of my talks where I'm talking about ECMO, where I have a picture of a couple of folks cannulating a patient on the floor of the Louvre
Yeah.
in
Yeah.
Paris, and that's sort of anyway. I think it's very interesting, and folks up in Minnesota that are really doing a lot of really good work in terms of pre-hospital ECPR and such. So you started to talk about airway management, and as respiratory therapists, sort of like you mentioned, there's a high variability in engagement and autonomy and et cetera, et cetera. And there's some respiratory therapists that are super experienced in airway management. Like when I trained at the place that you did your residency, we were responsible for all of the intubations, urgent intubations outside of the operating room, and I've intubated people in your emergency department several times when I was there. But there's high variability in terms of experience and responsibility for airway management. Tell us about your nightmare airway management.
I would say the nightmare airway is one where you haven't taken the time to prepare the patient or anticipate the issues that are going down the line. I think we sometimes talk about these crash intubations. I'd say you can count on, one part of your finger of one hand the time when somebody really needs a crash airway. And I think more often than not, we're able to think about our airway plan and have an opportunity to try and optimize these patients before we move on to them. Because I think the biggest, people talk about, some sort of anatomical problem that could be a cause of difficult airway or something else. To me, it's the not having anticipated what might go wrong with the patient when we essentially take over their ability to breathe and protect their airway and decide to put a tube down and give them medications to facilitate that and things. So I think taking the time to be able to optimize the emergency airway is super important. We have to be and thankfully, over the last decade or so, we've really emphasized and moved away from the focus on anatomy as the problem to the physiology as the problem. The patients we're intubating are often either bleeding or in septic shock or markedly hypoxemic or have some right ventricular problems that could cause challenges when we move them to positive pressure ventilation. Understanding the physiology of the patient and optimizing that as best you can is super important. I think one of the most useful things that we sometimes forgo appropriately is good pre-oxygenation. And so we've really moved, I think, to understanding that better from using nasal cannula to provide apneic oxygenation. There was a paper a few years ago that said that it's actually safe to bag valve ventilate these patients during the paralytic while the paralytic's kind of starting to work, which is really an interesting time because depending on which paralytic you end up using, you could have 45 seconds to a minute where this patient is essentially apneic. And certainly if, for example, you're intubating someone with severe metabolic acidosis, that could be
Mhm.
pretty physiologically challenging for those to not have any ventilatory effort during that time. I mean, there could certainly drop their pH and move them towards significant hemodynamic instability just in that period. So just doing that as well. And then more and more so we're learning that pre-oxygenation with non-invasive methods like using a non-invasive mask or even high flow nasal cannula could be really ideal for patients, positioning them appropriately, keeping them in a position of comfort while they're awake, and then maybe ramping them up a little bit, head up 30 degrees, things like that could really do great things to try and optimize these patients. So for me, that's the nightmare airway where we haven't anticipated those things and haven't tried to at least attempt to optimize things in order to prevent post-intubation complications.
Do you think, sorry, Keith, I have a question. Do you think, the traditional assessment of airways, the Mallampati score, like all of the stuff that we've been taught to do prior to intubation, do you feel that the growth of video laryngoscopy has sort of um, reduce the occurrence of this happening in some people, like maybe given them more confidence and sort of they're maybe missing, or I don't know what the word is. I don't want to say making some people lazy with doing a proper assessment because they just feel that the video, having the video there assists them so much in visualizing an airway that they often forget to check whether or not this person is quite difficult. Like, do you think there's been a
Yeah.
little there's it's creating a bit of a, again, I just want to say on the record, I'm not anti video laryngoscopy. Like, I think it's a great tool, but I wonder sometimes if it provides this overconfidence where people are sort of neglecting some of the basic airway assessment skills that we sort of required when we knew we had to put a metal laryngoscope into somebody's mouth, and like,
Yeah.
the real risk of like
Mhm.
breaking the teeth. And I know there's still a risk with video, but I think you understand what I'm asking. Do
Yeah,
you think
no,
there's been
totally. Yeah.
an issue there?
No, I think in part you're right, and I'm also a big proponent of video laryngoscopy. It has great safety issues, but I think it goes back even further. I think a lot of times the specialties that are being taught to manage airways become too focused on the technicalities of putting a tube into or through the vocal cords and forgo the training of how do you get a good jaw thrust? How do you
Mm,
do a good bag valve mask seal so that you're actually ventilating the patient? And I think that's a real skill that's even before video laryngoscopy became commonplace was missing. But you're right, well, I'll be able to get them with this, or I'll just change to hyperangulated if there's a problem. And goes, yeah, but anticipate that and look
Mhm.
at it. And, there is a challenge with using kind of the traditional tools that anesthesia have used for elective patients, like the Mallampati score. Oftentimes you can't do that for, in the optimal way that it's described to do for critically ill patients. But you can do a couple of things. So you can look externally, see if there's, what's your gestalt? Is this going to be challenging or not? And most of the times you can see what their mouth opening is. And even if they can't open their mouth, you can certainly measure the thyromental distance to see whether there's kind of a short neck or likely to be an anterior airway that you would want to use a different laryngoscope blade on. So I think that's something that we don't do often enough. And you're right. I think we've fallen into a little bit of a fallacy that, you know, we have these different configuration blades. If we run into trouble, we'll just use the other blade. And but you're then kind of backpedaling a little bit. You're behind the eight
Mhm.
ball, and the
mhm.
patient then runs the risk of deteriorating in your as you're kind of switching to a different techniques. I'm a big proponent of saying that the patient is not going to get saved by you putting plastic through their vocal cords. The patient is going to get saved by you being able to oxygenate and ventilate the patient.
Mhm.
And you have to be able to optimize that and be able to do that well. Because if you do run into trouble, then that's going to be your backup that you're going to, um, uh,
You those are all really good points. You mentioned physiologic derangements prior to intubation, potentially becoming more acidemic, et cetera. One of the other shifts I think that's occurred over the last few years is sort of resuscitation before intubation. And I can remember the days where we used to give everybody a couple of milligrams of midazolam before we intubated them. Somebody who's in extremist respiratory distress has had this catecholamine sort of surge from being in respiratory distress, and then you knock them out with the benzo, and then all of a sudden they lose that catecholamine surge, and then they become significantly hypotensive. It seems like we've gotten a lot better at that. How do you choose? How do you pick and choose a patient where before you intubate? Because intubating somebody is not fix for shock, right?
yeah,
It can only make it worse.
right.
So, but we intubate a lot of people that are in shock of all sorts of etiologies. How do you pick and choose a patient that you're going to treat and pre-treat for shock before you intubate them?
Yeah. Yeah, no, it's a good question. And I'll give you like an example of, say, a DKA patient, so diabetic ketoacidosis. So a lot of times, especially with severe illness, they'll be markedly acidotic. They'll have a profound metabolic acidosis. And, you know, they, they often look really, really bad when they're that acidotic. They look like they're like breathing 30 times a minute or more, and they're like sweaty and looking kind of confused and things. And some people, they might say, oh, wow, they're so acidotic and altered that we should intubate them. And those, you know, understanding that trying to intubate those and trying to match their minute ventilation on the ventilator can be really challenging when they're going that fast. That's the one I'll say, okay, let's just stop and understand the pathophysiology. They're so dehydrated that let's try them first with getting fluid resuscitation on board and making sure that they then have the ability to kind of perfuse their brain and resolve some of the dehydration that's causing their acidosis. And then we'll see if we need to intubate them or not. And more often than not, in that situation, you'll see that resuscitation approach first has allowed you to then avoid intubating that group. The other ones are the patients who are in septic shock. So oftentimes they'll be hypotensive, and you know that both the medications as well as the transition to positive pressure ventilation will decrease their venous return to their heart and decrease their cardiac output. And so, again, optimizing them before you attempt to intubate them is really important. So, you might, in that case, give volume, but you also might start them on pressors before. So, really understanding what the pathophysiology is really important before moving to intubation. It kind of goes back to my earlier point that rarely do people need a crash airway right away. A lot of the times you can look at their physiology and see what you can improve upon before you're moving to that, while providing some less invasive means of airway and oxygen therapy to try and get them to that spot where if you do then proceed to intubate, then you can have as best a situation as possible. So I think it is a case by case basis, Keith, and it really depends on understanding that physiology.
Yeah, yeah, that all makes sense. So let's talk a little bit about that. Okay, I get it, and I completely agree with you that most patients don't need to be intubated immediately. That you can sort of stand back, look at the total picture. Do they need crystalloid? Do they need pressors? Do they need something else before you? Do they need reversal of narcotics, et cetera, et cetera? Is there something else we can do that's before we just make that decision to intubate? But let's just say that patient does need to be intubated emergently and right now, right here, right now. And let's say they're the worst nightmare case where you can't intubate. You attempt it. You have the most experienced airway manager in the room attempting to intubate. Can't get them intubate. Can't ventilate. What's your preferred next step?
Run
Yeah.
away.
Help. Yeah, those certainly challenging, and yeah, those can be really, especially when it's kind of unforeseen.
Yeah,
Crap, you look down
snuck up on
and
you.
you see, oh my God, I can't see anything, and I can't even ventilate. So I think breaking it down a little bit. So one is can't intubate, but can oxygenate. So in that instance, I will, if I've had, as the most experienced person has had to go and they're not able to intubate, then but able to oxygenate, then my preferred route would be to put a supraglottic device down, so like an iGel or another LMA. And I think those are great rescue devices that can provide oxygenation and ventilation appropriately with a minuscule risk of aspiration, but still can provide you some time to be able to kind of rescue the situation while you're deciding what to do next. But if it's a true can't intubate, can't oxygenate situation, then the next step will be kind of what's called the front of neck access or the surgical airway approach. And I think there are cases where that even might be unanticipated. You thought that it'd be a straightforward intubation and suddenly you run into trouble. But again, kind of going back to being able to do that pre intubation assessment, you might predict that this might be a case. And if possible, you might say in your plan, okay, my A and B plan are to try and go orally, then use a supraglottic device. And my C plan will be to do a surgical airway. And I think if you have the ability to anticipate that, then and communicate that, that really goes a long way to taking down the tone in the room. Because a lot of times when we move to a surgical airway, people are like running around like crazy and go, "Oh my God, there's a surgical airway happening," and everybody kind of gets their adrenaline level goes to extremes. If you have the ability to kind of anticipate that as you're setting up for the airway, that's ideal. Sometimes you don't, and sometimes you just have to, in your mind, be ready that okay, this is always going to be my last step to in this airway to be able to ensure that they're able to be oxygenated and ventilated. And these are rare procedures, and I think it's really important, and it behooves us as kind of critical care practitioners to practice that in any way we can. So one is by doing, say, simulations on this, where you can have scenarios, and now these mannequins are cool enough that they can mimic like really bad oral airways. Second, also, I think is almost like mental rehearsals. So you can like think about or talk about, say, at the beginning of a shift, hey, maybe we'll have to do a surgical airway. Let's just run through the steps in my mind, or in chatting to your colleague, if we ever have to run into this, let's just talk about it so that if push comes to shove, we at least kind of have that mental model in our headspace to be able to do it if needed. And then third is also sometimes understanding that at times the surgical airway might be your initial airway, and that's okay. It's not a failure. We often think that this is a failed airway if we're moving to surgical airway, but sometimes these patients might primarily need, say, you get someone with severe facial trauma that is, their whole face is blown off and they have no landmarks for you to be able to put your laryngoscope in, or the airway is too soiled for you to use a video scope in because the camera always gets occluded, or they have like significant angioedema or something like that, then you might think, okay, this primary airway is going to be the surgical airway. So when you can anticipate this, then certainly communication to the team is key. Mental rehearsal is really important. And then sometimes understanding that that might be your primary airway is also key.
Yeah, that's a really good point in terms of preparation, like just being mentally prepared. Like, when I go to work, one of the first things that I do is check the glide scope just to make sure that everything's on there, that, capnography, stylettes, ET tubes of all different sizes, some, all the things that you might need. Also, part of my mental checklist is to make sure that I know where all the difficult airway stuff is, that it's where it's supposed to be. Then that's before I even do any, see any patients, just because I know that for that time period, I'm going to be the one that somebody says, hey, grab this,
Yeah,
or
exactly.
go find this. And I want to make sure I know where that stuff is before I get
Yeah.
started.
And more often than not, it's like, that'll never happen to us. And then the next case rocks up
Yeah.
where it's like exactly that.
But it happens all the time on TV.
Yeah, yeah.
Right? Yeah.
Yeah, I remember many years ago, I read an article about retrograde intubation. And the very next day, I got called to the oncology unit where this person had had extensive radiation therapy to their neck that needed to be emergently intubated. And I went in
You're
with
like, I
DL
got this.
to look, and there was nothing identifiable whatsoever. So the resident that was placed in the central line, I said, "Hey, listen, this might sound crazy, but take that introducer you got there, stick it in their neck, and point it north, and send that wire up to me." And so I did. I did retrograde
Wow.
intubation using the wire from the central line kit, and yeah, it worked out fine. And
Wow, wow. I have to say that's one thing I have not done yet, but that's cool.
yeah,
Yeah. But
yeah,
it kind of brings up an important point, right? It's like, it's we as a team need to be kind of thinking about those scenarios because it shouldn't, and it's not just for airways, but like a lot of kind of critical care management. It shouldn't matter whether I'm specifically on or you're on, Keith, or you're on, Thomas, that has read about this or done this. We should be kind of talking about this amongst our group so that whichever day of the week it is, and whoever is on will be in the best position to be able to, if not do, then at least kind of bring it up that, this is an option that we should kind of try and explore because it really is, I won't say random, but you're not always there and it shouldn't be just you having this knowledge, but we should certainly talk about this amongst our colleagues. Say, hey, I was just watching this cool video. Let's talk about this and things like this, so that everybody's kind of on their best foot when they're kind of faced with these kind of scenarios.
Yeah,
yeah.
I
I think
feel like
that's
there's
our
sorry, go ahead, Keith.
I think that's our aim with this podcast and with our panel discussions and with our approach to education is to just sort of try to get things out to the masses, and I've always said that unfortunately, and I think maybe this is getting better, but through educational efforts and through folks like you, Zaf, that teach and that they're passionate about spreading knowledge and understanding. But I feel like at some point in time, you as a patient, your chance of survival is at least in part dependent upon who is at the hospital when you get
Yeah.
there. And that can be the ER nurse, the ER resident, the ER attending, the ER RT, anybody on the team. It could be anybody on the team that may not be prepared, may not
Yeah.
be know the things that they need to know to take care of the patient. And it's a system problem, I think. And I think that it's gotten better, but it shouldn't depend on, like, to your point, it shouldn't depend on just one person understanding, and they're not understanding a specific technique that could be life saving, but they're not here today.
Yeah.
I agree with
Yeah,
you
I
100%.
I think there's a huge power in case report sharing within your institution. In my years as an educator, probably one of the most important things I could do was take a case that most people were familiar with because they heard about it and write it up in like a proper presentation format or in like a handout. Like sometimes I would describe a case report on a piece of paper with like screenshots of like the ventilator waveforms and then links to research papers that might be directly related. So for example, Keith just learning about something and then the next day it happens. Like that should have been written up to share with others, being like, this is what happened. This is how we how we managed it. Here's some resources so that you can learn more about this. And then sharing this information. Cause I think, there's always a lack of education when super interesting things happen. It's like, how do we disseminate this to everybody else? How do we explain the importance of this? But this is really the power of explaining a specific case, because then you'd be like, you're going to get some clinicians like, I remember that patient or I remember
Mhm.
that. Or they heard at handover, like, oh, you should have heard this. And then a week later, someone's like, oh, this is what they were talking about. Here's a slideshow or here's a PDF or here's a handout, like explaining what happened. We should learn from this. And I think we need to increase, I mean, we do things like simulation and you have debriefing and stuff like that. And when horrible things go wrong in a hospital, usually there's a debrief at some point where people talk about their feelings and stuff like that. What went well, what went wrong. But I think there's probably many moments where it's not something that went horribly wrong, so there's not a proper debriefing, but it's
Mhm.
a huge learning experience that we really should take advantage of and really try to disseminate that knowledge. I'm big on knowledge translation, so that's, to me, it's like if something cool happens, you want to make sure as many people know how it was
Mhm.
handled, and then any resources that could help them understand what was done and why.
Yeah. And the other thing I think is that we often, as a group, don't debrief on when things go routinely
Mhm.
well because
Or
and
why
I've
they went
talked.
so well. Like, why did they go so
Yeah.
well?
Yeah,
Yeah.
exactly. Yeah. I've caught myself a couple of times, that obviously as you get more experience, and you guys will probably know the same, things just, our mind works in different ways and we just kind of go through the process and do things. But, it's sometimes when, the learner then asks you, hey, I saw you do that, but, how did you decide in this situation to do? And this is something, that's second nature to us as we get more experience. But
Mhm.
sometimes we forget that it's a learning curve to be able to make that decision making on the fly, and kind of anticipate things, and tweak things a little way here or there. And we need to share that stuff as well, because that's the important things, and those things that we've learned to be able to do the routine things routinely well. So
Yeah, I think
I
that's
think we,
important
we,
because
we
you have
need to do a
learners.
better job at that.
Yeah, you have learners, but you also have new staff. Like there's,
Yeah.
staff turnaround is a thing. And if that new staff is not accustomed to the routine practice and why does everything just click? Like, why when you're in the emerge do things just go smoothly? And it's like, well, that's
Mhm.
because of this experience. And like again, reviewing that with not just learners, but even new staff. Like you might get, and I know in the US, like travel RT and travel nursing is
Yeah.
is is a big thing. We don't really have it's not as big in Canada. But, you know, people coming in that don't understand why things just run so smoothly when certain people are on, and it's that experience. But you're right, I don't think we highlight, why does this work so well? Like, so sort of stepping back and being like, we're really good at this. Maybe we should like highlight and like maybe present a case and like explain why this went so well. But you're right, we usually just debrief on the horrible things that happen,
Yeah.
mostly for our own mental health.
Right.
But in terms of experience, I think the simple things that are second nature to us probably have a lot of value in teaching that to not only learners, but new staff or travel staff.
Good points, and so that they could be repeated, so
Mhm.
people can understand why this went so well. Yeah, completely. Anybody want to kind of bring all this stuff home? Steph, do you want to
Mhm.
just talk about? So you did bring up front of neck access, and have you? How often have you had to do that? Have you had to do that before?
Yeah. In reality, I've only had to do it once, so touch wood. But
I was going to say
Yeah,
knock on wood. No one
it was
wants
yeah,
very
as
maybe.
stressful. Yeah,
as
it was
cool
very
as
stressful.
it is on TV. It's this
No, it's
extremely
not.
stressful
Yeah, it's certainly
situation.
it's funny. I was watching this show just the other day. It was a police procedural, and they go up to this scene where they say somebody was choking, so their friend decided to try and crike them, and ended up like killing them because they hit the carotid. But just
Oh,
an
jeez.
aside.
You don't
Yeah.
do that.
Yeah.
Don't
But
cut the red
yeah.
wire.
Yeah, no, it was actually part of my practice. I do some pre-hospital care, and there was an unfortunate motor vehicle collision victim that I had who we couldn't intubate and couldn't ventilate, and so I ended up having to do a surgical airway on them, and it was pretty stressful to do. I felt I've been lucky. We've had access to a regular cadaver lab that I help run here at Penn, that we teach. Our faculty to do surgical airways. So kind of the muscle memory was there. But I have to say, even when the muscle memory is there, individually we'll be doing this pretty infrequently. And so when push comes to shove, there is still, the anxiety that is related to that procedure. And so you have to, um, even with the preparation and the talk and mental preparedness, it can still be pretty stressful when you're actually in that situation, and life is on the line for it. So probably emphasizing even more that anticipating and preparing for this as best you can is really important, just to try and minimize this, because I think if I hadn't had that, then I would have probably been even more, sometimes even the paralysis to initiate, or the inertia to initiate the procedure when that's what's meant to happen. I
Mhm.
think that would certainly have played into my actions if I hadn't gone through some of the work on the cadavers and mental preparedness. So,
It was a huge conflict in your mind, right? It's just like, I know
Mhm.
the skill, I know I
yeah,
can do this, but the
But I don't
last time
wanna.
I did th the last time I did this, the person was already not alive because it's a
Yeah.
yeah,
cadaver. So then you're like
yeah,
taking that into consideration. You've got, a conflict going on in your mind. You're like, do I go ahead? Do I do this? But yeah,
yeah. And I
it's a
think that's
stressful.
That's why I emphasize that, the surgical airway shouldn't be seen as a failure, because I think using that word, that this is a failed airway and we had to move
Right.
Mhm.
to front of neck access, puts people off even more from acting when they should, because they'll be worried about how their actions are perceived when this is under the spotlight down the line, which inevitably it will be. And
It should be
so,
more like how can we ensure success with this airway? And if
right,
that's
exactly, yeah.
and
Mhm.
that may be the solution that provides the most success.
Yeah, yeah, exactly. This is part of the airway plan. Maybe it's part A or maybe it's part D, or but it's part of the airway plan, and that's how we should be thinking about it. But ultimately, I think that, Keith, when you said, I kind of summarize what we've been talking about, I think what we really need to kind of wrap this around is preparedness and anticipation of what we do to our patients that affects them. And that includes, the peri-intubation period, but also the immediate kind of early critical care management that happens with these patients. We talked a little bit about talking to our colleagues about optimal ventilation strategies for this particular patient. Not everybody has the same prescription for a ventilator, and so there needs to be that discussion up front. And really, we need to communicate better as a team of medical professionals in what we are trying to achieve in terms of goals for our patient. And everybody can provide input. Everybody is a little bit fallible and forgets things. And so that's where our team really comes in, to be able to feel empowered enough to speak up and be able to optimize the preparation and planning for, the most difficult day in that patient's life. So that's, I think, can be a nice kind of bottom line message for your listeners about kind of critical care and emergency department airway management.
It's great.
That's a great wrap up.
Yeah.
Really appreciate
Now,
it.
I have one last thing before we
Yeah.
wrap up. As an emergency person, do you watch The Pit, and what do you think?
Yeah, I do. Yeah. I thought, certainly season one, I thought was the first time that the reality of what we face in the emergency department was really emphasized, and not just the cool cases. And certainly they do more, just from dramatic reasons. They have more crazy cases than in
Of
one shift,
course,
but
yeah.
the things like the overstaffing, overcrowding and understaffing, and the potential for violence against staff members, and
Mhm.
the
Yeah.
constant stress that people undergo. And what really hit home for me was, as with, I'm sure, a lot of people who are kind of frontline with the sickest people during COVID, was the real
Oh, the
lasting effect that
PTSD.
that had
Yeah.
on our mental
Mhm.
health. And
Yeah,
so,
yeah.
making that seem okay to talk about was something I'd struggled with for a long time
Mhm,
personally, because I felt like people didn't understand, just the brutality of what COVID was, especially early on,
mhm.
Mhm.
and the amount of death and stuff that we were facing during that time.
Well, and I think the fact that the person with that they highlighted the strongest PTSD with was the attending. Like, it
Yeah.
was
Yeah.
someone who you expect to, like, have it together all the time, you
Right.
know? So it was like, humanizing that as well because,
Yeah.
we've heard from RTs and nurses about PTSD. Like, I feel like we've been the most vocal about it. Perhaps maybe because I'm in my own little bubble of like allied health professionals, but the fact that it was a physician that was the one who was struggling so much, and it was due to a lot of it in part because of it. A mentor of his was one of his sick patients. I thought it was
Yeah.
a really good story. My only criticism the first season was that I'm like, where's the RTs?
Yeah.
Like, every once in a while you hear the word RT, but like they're intubating and it's like it's just nurses and doctors, and I'm like, why is there
Yeah.
not an RT there? And then this season, so I did see an interview where they said they were gonna try to get more RTs. So I did
Uh-huh.
hear someone who was probably an RT say the
Yeah.
vent settings the other day. They're like,
Uh-huh.
AC 500, 50%. But I'm like, but there's no main character as an RT. And it
Yeah.
just seems strange because I'm like, I'm pretty sure we're more involved in the emergency department than what's being portrayed. But the fact that the story, the accuracy is probably one of the more accurate shows
Yeah.
that have
Yeah, I
ever
agree.
existed, and I think that was something they really wanted to try to do. Really worth the Emmy wins that they got. I
Yeah,
feel like I'm
totally,
really
yeah.
really enjoying the show. Yeah, so I
Yeah,
just
you
had to
should,
ask it.
you guys
Yeah,
should, petition the, writing
RT
team
thing.
to include RTs for season 3.
It's
Yeah,
too much like work. I watched it, it's like just like being at work.
yeah.
Too much stress.
I've seen a lot of clips online of like watching this show with my ICU physician wife or like my ER husband is like,
Yeah.
and they're just recording their responses and like they're saying things before they're happening. I was
Mhm.
Yeah.
watching it with my partner the other night, and when spoiler alert, the lady has an infection in her leg, and we both looked at each other. We're like, Oh, that's neck fash.
Yeah.
We knew right away, we're like, "Oh, that's not good. That's probably neck fash." We're like, "Oh, yeah, that's gonna be neck
Yeah.
fash."
But it's
So
really, I grew up watching ER and, just seeing how the accuracy has been improved through the years on this
mhm.
and kind of more of the focus on the rest of the team as well. And the realities of kind of our kind of broken healthcare system in the United States.
Oh, there's so many hints and not jabs, like, 'cause it's not trying to poke fun of something. It's highlighting,
It's
like,
reality.
actual
Yeah.
it's
It's just
reality, like,
reality.
Yeah.
highlighting actual
Yeah.
realities that
Yeah.
Yeah.
everyone faces in this, in the current, emergency room environment. So, yeah,
Yeah.
anyways, I had to
Yeah.
ask you because you're the first person involved in emergency medicine at a physician level that I've spoken to, that I've had a chance to ask about that show, so.
Yeah. Yeah.
Yeah.
No, it's a
Well,
great
John
show.
Carter's come a long way, hasn't he?
Yeah, I wish they had kept the same name of John Carter,
Uh-huh.
from ER. In fact, when I saw this show was, first being advertised, I was just
Uh-huh.
like, "Oh, no way, this is like a continuation," and I was so disappointed, but apparently there were some discussions, but they couldn't reach an agreement, so they just made it completely on their own, which
Yeah,
is
that's what
good.
I
It's a
heard too.
very
Yeah.
different show. Like, if they had tried to continue ER was sort of more of a drama series
Uh-huh.
with, like, that took place in Emerge, where this feels
Mm.
like this is like an emergency room with the normal emergency room drama. Like,
Yeah.
it's more integrated, I feel, for
Mhm.
sure.
Oh, yeah,
Yeah.
yeah, and we all know there's enough drama to make, several shows.
For
Yeah.
sure.
Well,
For sure.
Zeph, we really, really appreciate you coming on today, and it was good talking to you, good seeing you,
Yeah,
and
likewise.
we'd like to have you back sometime. If you
Sure,
think of
yeah,
something you
more
wanna
than
talk
happy.
about, then just reach out and
Yeah, no, that'd be great. It's an honor to be part of this. I appreciate it. And just a shout out to all of my respiratory therapy colleagues. We can't do the job that we need to do without everybody on the team, and RT is a really important part of that. So I appreciate you guys putting this podcast together to get the knowledge out there. And it's been a pleasure being part of it.
well, we
Awesome.
appreciate you,
Thank
Zeph.
you.
Thank you so
All right.
much.
All
All
right.
right, take
Take care.
care.